We are live. Welcome everyone to tonight's live expert session with Lupus LA and Dr. Reddy from UCI. We're just getting started here. I'm going to wait for some people to trickle in. But Dr. Reddy is an expert nephrologist in the kidney and pancreas transplant program at UCI, and he's here with us tonight to answer your top questions around kidney failure and kidney transplants in lupus. This can be a bit of a daunting topic, so we're very pleased to have you here tonight to discuss the ins and outs of how transplants are approached in this population. And if you're just joining us, please feel free to drop any questions that you have in the comments or send us a DM. And as usual, we'll ask your questions anonymously on your behalf. Dr. Reddy, would you like to kick us off by sharing a little bit about yourself before we dive in?
Yeah, sure. Thank you everyone from Lupus LA for having me today to speak about lupus and kidney transplantation. The field of kidney transplantation is near and dear to my heart as the medical director here at the UC Irvine Kidney and Pancreas Transplant Program. I'm a nephrologist that went on and did an extra year of specialization in kidney transplantation at UCLA. I was a faculty member at UCLA for a few years before jumping down south to UC Irvine, which is about 30 minutes away. And I started in 2015 as the medical director of our kidney transplant program here. Our first year, we were building the program. We did 34 kidney transplants here at my first year. We're currently on pace for 175 to 180 kidney transplants this year. So we're very proud to be the fastest growing kidney transplant program in California, and we also have very, very good outcomes. So we hope to be a resource for anyone that would need our services. And I hope you guys enjoy the topic today. I'll have a few slides, just basic slides about the field of kidney transplantation. A lot of people don't know about it. And so I just want to introduce you into the world of kidney transplant and then follow up with any questions that you may have. We have some questions that were submitted that we will review, and if there's time, we could add questions too. So thank you everyone from Lupus LA. I can't see you, but I can feel you. All right, so my first slide. So this is a slide of all the famous people that have gotten a kidney transplant. Sometimes when we have a health issue or a health journey, we feel alone. And I only share this slide and I share it with some of my patients so they know that, this can happen to anyone. It's not anything that anyone did. And, Selena Gomez, who probably has more Instagram followers than anyone in the world, she had lupus and eventually got a kidney transplant when her good friend donated a kidney. George Lopez got a kidney transplant almost 20 years ago or so. Alonzo Mourning, NBA champion from the Miami Heat, just celebrated 20 years with a functioning kidney transplant. Tracy Morgan, a famous comedian, has kidney failure due to diabetes, got a kidney transplant. Tina Turner had one before. Fife Dog on the bottom right from Tribe Called Quest also had diabetes and got a kidney transplant. So it's only a slide meant for everyone to feel that they're not alone, and it certainly can happen to anybody. So this is a picture of a kidney that's about to be transplanted, and that's what we're going to be talking about today. So I'm going to have a few slides about the background and importance of transplantation. So a lot of people think when you get a kidney transplant that we take your original kidneys out and like put the new kidney in, but that's not actually the case. So in the graphic on the left, you can see the two kidneys that we're born with, we don't touch them. And we actually place this new transplanted kidney in the right or left abdominal space. And the kidney comes with the artery, and it comes with a vein, and it comes with the ureter. And we connect this artery, vein, and ureter to the recipient. So the vein is connected, the artery is connected to the person's vein, and the ureter is connected to the bladder. And after a few seconds, this organ, which was on ice and in another person earlier, will start to turn pink. And once it gets its blood flow of the vein and the artery, it'll start to make urine. And that urine will flow down into the ureter, into the bladder, and voila, a person with kidney failure now has a second chance at life. So this is just a description or a depiction of how it is like anatomically. If a patient were to get a kidney transplant, they should know that the surgery probably lasts around 4 to 6 hours, variable depending on the complexity of the kidney and the recipient. Here at UCI, most of our patients are hospitalized for between 4 to 7 days after surgery. So it's not particularly long. We have some patients that are even strong enough to go home in 3 days. Because this is a foreign body, a foreign mass that is now entering your body, you can imagine that your body would want to fight it tooth and nail to get it out of there. And so the key thing in allowing a transplant to work for years and years and years is to put that person on immunosuppression. So we basically take their immune system and shut it down so that it doesn't fight the kidney, so the kidney can do its thing. So immunosuppression is necessary to keep the organ working. And it's very important to realize that after transplant, hydration is very important. I tell patients that your kidney is like a plant. You need to water that plant every day. And hydrating after kidney transplant will allow it to function better. When you get a kidney transplant, you usually can't work for 2 to 3 months. This is also a little bit variable based on each person, but we usually tell our patients to think about taking off for 2 to 3 months if they receive a kidney transplant. And then, like the anatomical picture showed, the surgery is in the right or left abdominal area, and you'll have about a 4 to 5 inch scar. And you can imagine your kidney is like the size of your fist, and you can imagine if there was some object in the right or left abdominal area, and that's kind of how it feels like to have a kidney transplant. So back to the immunosuppression. So lupus patients know all about immunosuppression, and you can think about kidney transplant has a lot of overlap with lupus, because in lupus, we're trying to stop your body from attacking itself. And in transplant, we're trying to stop your body from attacking the new kidney. So when you get a kidney transplant, we give a lot of strong medications up front, because that's when your body's going to have a very strong response, because it sees this foreign object. So in the hospital, while you're in the hospital for that first week, we're giving strong IV medications to stop your body from rejecting the kidney and essentially stopping your T cells from being activated and your B cells from being activated and your immune system from being activated. And after that period of a week of induction therapy, where you're getting these strong IV medications, we will give you then oral medications that you take every day to suppress your immune system from attacking the kidney. These essentially will be needed for the life of the transplant. As long as that kidney is in you, you'll be needing those medications. And so just like with lupus or a lot of other diseases, compliance is very important. If we don't have that 24-hour security in the body of protecting that kidney, then you can get rejection. And so compliance is very important. And like I mentioned earlier, the medications that we use in our world and that lupus patients use are very similar. Cellcept and prednisone play major roles in our immunosuppression. Cellcept and prednisone are two out of our big three biggest medications that we use. And so essentially, there's a lot of overlap between the world of lupus and the world of transplantation from an immune system standpoint. So when a patient is faced with kidney failure and dialysis and the prospect of transplant, it's natural to just kind of feel down and feel sad and like, why is this happening to me? But some things to understand about the speck of time that we right now, our generation and the generation before, is 100 years ago there was no dialysis. 100 years ago there was no transplant. So when humans had kidney failure, that was it. And now we live in a time where dialysis can be a bridge to a kidney transplant. And so this slide depicts the idea that our first kidney transplant was not that long ago. Now I think I have to update my slides. Less than 70 years ago was the first kidney transplant at Brigham and Women's in Boston. And at that time, we didn't have immunosuppression. And the lead surgeon had this twin pair where one twin had kidney failure and the other twin didn't. And he took a kidney from the healthy twin and transplanted it in the twin with a kidney failure. And he went on to live, 8 more years. And at that time, that was a tremendous feat to have 8 more years of life. And so that lead surgeon that tried that experimental surgery ended up winning the Nobel Prize for his work in organ transplantation. So this slide is just meant to show that as awesome as kidney transplant is, it's such a new thing. Doctors, before 7 years ago didn't have anything like this. So as we think about kidney transplant, I want you to understand there's two main types. A living donor transplant, which is what we recommend for everybody. And if you can't have a living donor, then you'll enter the waiting list and wait for a deceased donor kidney transplant. So the majority of transplants in America are deceased donors, but we recommend patients getting a living donor because you won't have to wait as long, and it's a better quality kidney and they last as long. So, so two types of transplants, the living donor transplant and the deceased donor transplant. And we always want to promote living donation. So why is transplant so important? So the first reason it's important because of survival. It comes down to life and death sometimes when we're talking about dialysis versus kidney transplant. This is a slide looking at the survival of a patient who's had 5 years of a kidney transplant, which is like still way over 80%, versus the survival of someone who's been on dialysis for 5 years, which is 35 to 40%. So just forget traveling and dietary discretions. If you have kidney failure, you got to get a transplant because it's the best option to stay alive. Sounds good. So just get a kidney transplant. What's the controversy here? Well, the problem is the organ shortage that's happening in our country. So this slide shows that in the 90s, the amount of people on the wait list was just barely over the amount of transplants we were doing. But with time, with the aging population, people living longer, the dietary issues in this country and the amount of diabetes in this country, kidney failure has soared. But the amount of transplants that are happening per year, though they're highest ever, every year that passes, they're nowhere near the amount of patients that are entering kidney failure and needing a kidney transplant. So we have a tremendous supply and demand issue in this country. And the blue donors are the living donors, and the red is the total number of transplants. So probably 2/3 of the transplants we do are deceased donor, and maybe less than 1/3 are living donor. And so, if there's things we can do as a society to increase living donation, I think we can only then start to shorten this gap that we see with the wait list, expanding and expanding. This slide is just meant to show, there's a lot of other organs that you can potentially transplant, but kidney transplantation makes up the majority of the field of organ transplantation. So in this slide, you can see that in 2021, there were 90,000 people that were waiting for a kidney transplant, and we did 25,000 transplants that year. Whereas with the livers, there were 11,000 people waiting, and they did 9,000. And with the heart, because without the liver and the heart, there is no dialysis. So if a patient passes away, then they're no longer on the list, and they no longer can get a transplant. So because of dialysis, there's such a big gap. But more than the gap, you can see the sheer volume of patients is highest with kidney. So we make up the bulk of the field of organ transplantation. Just some stats. So current stats, we're currently at 103,000 people in America waiting for a life-saving organ transplant. And of that 103,000, 86% are waiting for a kidney. So again, we make the bulk of it. In 2023, that was the highest year that in terms of number of transplants in this country, at 27,000, highest ever. But it just pales in comparison to the need. For those of us in this Lupus LA group that are here in SoCal, Southern California, the transplantation organization of the greater Los Angeles area, which includes Orange County, is called One Legacy. It's an organ procurement organization. And they're the ones that will speak to the deceased donors about donating, and then they will coordinate the allocation of those organs to all the local transplant programs. So every day, all of us local transplant programs are essentially competing for these kidneys that are procured by the organ procurement organization. So it's not a race to who can get to that hospital the fastest. We have an allocation system in the field of kidney transplantation that's recognized by an entire country, and it's divided regionally. So in Florida, for example, the wait time for a kidney transplant might be 2 to 3 years. In America, the average wait time for a kidney transplant is about 4 to 5 years. Here in Southern California with One Legacy, the wait time is the longest in the country, 8 to 10 years. When I go to national conferences and I talk about the 8 to 10 year wait in California or SoCal, people that aren't from here are like gasping in the crowd that I can't believe people have to wait so long. So it's unfortunate, and the powers that be with organ allocation are definitely working on different strategies of allocation that are not so regionally, dismal for our area. So we'll see hopefully in the next couple years if we change that. But what happens is when a donor passes away, depending on the blood type of the donor, the organ is allocated. So if someone is an O blood type recipient, they can only accept a O kidney. So that's why the wait time is the longest. But if someone is an AB blood type, an AB person can accept a kidney from an AB, a B, a A, and an O. So the pool is bigger, so the wait time is less. And your position on the waiting list is essentially when you started dialysis. So if I started dialysis 9 years ago, but my friend started dialysis 9 months ago for the same blood type, my name is way higher on the list because the list is organized by your position, by when you started dialysis or when you were listed for transplant before you started dialysis. So just a thing to know about organ allocation. If there are local people in the crowd, these are the centers that do transplants in our area. UCI, we do about 170. St. Joe's across the street does about 80 to 90. UCLA is one of the biggest transplant programs in the country. They do 350 to about 375, sometimes 400 transplants. USC's pushes between around 200. Cedars, also a major transplant program, does 250 to 300 transplants. Loma Linda does 200 plus. And Harbor UCLA, a smaller transplant program, does about 25 to 30. And so anytime a kidney comes in this area, all of our programs are offered the kidneys. And depending on where our patients are on the list, based on when they started dialysis and their blood type, then we get the organs. And every donor typically has 2 kidneys. So one kidney might go to UCI and another kidney might go to Loma Linda. And there's 2 organs for donors for the most part. So I want to talk about living donation because I think deceased donation is fine to know about, but who wants to wait 8 to 10 years for a kidney? I mean, it's not something we recommend. So the real key, if you have kidney failure, whether it's from lupus or diabetes or from whatever, is we have to start thinking and talking to our world about finding a living donor. And when I say world, I mean like each person has their own world. And if it was me, I would talk to my basketball teammates, I would talk to my friends, I would put a social media blast, I would try to engage anyone around me to help me find a living donor. And so this is a slide that looks at the change in America in living donation. So in the past, it used to be that like you see in the purple, the amount of related donors was a lot higher. So usually you would only ask like your loved ones, your mom, your dad, your kid, maybe your cousin, things like that. And society has changed now. Now with social media and other creative things that are happening in transplant community, unrelated donors are rising, and related donors are kind of falling down. And the overall living donor rate is actually relatively stable. And I think we have to do something about that kind of together. If you can imagine, America has 330 million people, okay? And we did 6,000 living donors as a country. Let's say out of the 330 million people, I don't know, 10 million or 20 million are eligible, healthy living donor candidates. We're only getting 6,000 from there. And we have this huge pool of people waiting. I think the real revolution I think we need to see in the next, decade is expansion of living donation, and as a whole, probably another talk. But so one of the things we did to be creative with living donors is in the past, let's say donor one is my wife and I'm recipient one. So my wife wants to donate a kidney to me, but we are different blood types, so she can't. So in the past, that would be it. They would be just say, okay, go home and you don't have a living donor. But let's say in the room next to me, there's a brother and sister that are also not compatible because they had different blood types. Then programs started getting clever. They were like, wait a minute, this wife can donate to this brother, and this sister can donate to this husband. And that was the beginning of the paired exchange. And that allowed programs to kind of try to increase the amount of living donation by taking uncompatible pairs and making them compatible. Now, we took that even further. There are some people that wanted to donate just out of goodness of their heart. They always had good health. They didn't know anyone on kidney failure, but they just said, I want to donate a kidney. So if our program had 3 pairs of incompatible people, we take this altruistic or non-directed donor. Once he donates to the first recipient, then it unlocks all these pairs to donate to another uncompatible pair, and eventually, multiple people get transplanted. And that was the birth of the kidney transplant chain. And we're part of multiple chains, and now we're creative where we work with 80 different transplant programs, and we have chains where we have kidneys flying from New York kidney flying to St. Louis, and the St. Louis kidney flying to us. And it's pretty exciting to be a part of. So I'm selling you so far on the benefits of kidney transplant. Now, what are some situations where someone might not be a candidate for kidney transplant? So sometimes people have like real severe infections where if I shut down their immune system, that infection is going to go crazy, and maybe this ain't not the right time for a kidney transplant. So a recent infection or even a cancer with no immune system, the cancer could take a hold of the person. So those are sometimes contraindications. If someone had an uncontrolled psych disease, then we weren't sure they would be compliant with their medications or whatever, that's a contraindication. Kidney transplantation requires a lot of support. You're not going to be able to work or drive for a first month. You might need help taking care of you after the transplant for a few weeks. So having some support is important to us. If someone is smoking cigarettes, we're not going to transplant them and try to enhance their health when they're doing an activity that actively worsens their health. Sometimes when you have a kidney transplant candidate and they're really severe heart disease or liver disease, then maybe they're not a candidate for a kidney alone and they need a dual organ transplant. Age used to be a contraindication to a lot of programs in the country. For us, we don't have an age cutoff. Age is still a real thing. It's a biological risk factor. In the past, the cutoff was 70, but we've transplanted people up to 79 that were healthy enough. More important to us is how strong they are, how well you move, how functional you are, than the actual age. Just the other thing I want you to realize is, dialysis treatments in the United States are very expensive. Hemodialysis is very, very expensive. Peritoneal dialysis is a little less expensive, but still expensive. And transplantation actually is the most cost efficient. So not only is it saving lives, but it's also cost efficient. And so for the government, which is paying for dialysis, there's a big push to kind of increase transplantation in this country. And so we're seeing a lot of initiatives to try to push and promote transplantation. I'm almost done with my slides, but just want to share some key stats. So Southern California, again, has some of the longest wait time for a transplant in the country, 8 to 10 years for most blood types. Now, if you have a living donor transplant, you don't have to wait 8 to 10 years. If you're compatible to your living donor and both are cleared, at UCI, you can get a transplant between 3 to 6 months. If they're not compatible blood type, then we put them in our National Kidney Registry chain, and we can find a kidney again in just a few months. So living donation, these numbers don't apply. Now, let's say you get a kidney transplant. First thing patients like to ask me is like, how long is it going to last? They don't come with expiration dates, but in general, deceased donors tend to last about 10 to 12 years. It's just the average. and living donors last upwards of 15, sometimes 20 years. Again, I had transplant patients that have had their organs for 40 plus years. So these are just averages. In our area, the average age of a waitlisted patient is between 62 and 64 years, and all transplant programs also are mandated by the government to have good outcomes. Government doesn't want you to take a scarce resource and just like give it to people that they're not going to live long or not going to take care of it, and so there's strict kind of criteria on patient and graft survival that they expect, and for us they want us to be successful for patient graft survival upwards of 95% for the first year. So besides, the mortality benefit and the cost benefit, there's a huge quality of life benefit. So when you're on dialysis, it's often a very restricted diet. But with the kidney transplant, diet is much more liberalized. Patients can kind of eat what they want. They tend to gain weight after transplant, so we often have to kind of hone that in a little bit. Traveling on dialysis is very difficult if you're on hemo or PD, but once you get a transplant, you're free to travel again. One of the most gratifying things for me as a doctor has been able to take a young woman who thought that she'd never have kids because she had kidney failure. They get a transplant and she's able to become pregnant. And, we've had 20, 25 plus births here in the 9 years I've been here. And it's amazing to see, young women, start their own families, and all of that comes with the kidney transplant. Also, just lifestyle constraints, with dialysis that you'll be free of. People can work more, bring more money back to their homes and their families. If they're in construction, gardening, painting, whatever it is, you're going to have more physical strength and able to bring more back to your family. So quality of life benefits are very, very important when you think about kidney transplantation. So just to summarize, just the world of kidney transplant, compared to dialysis, patients live longer, have a better quality of life, save on overall medical costs, and in our belief, it's the optimal therapy when you have kidney failure. I have 2 slides about, as I connect lupus more into, kidney failure and transplantation. So, when you have lupus, end-stage kidney disease represents one of the most severe manifestations of lupus. It doesn't happen to everybody, but when it happens, it is a pretty significant deal. Up to 40% of lupus patients will develop CKD, which is called chronic kidney disease. Doesn't mean it's kidney failure, but some level of kidney disease, whether it's proteinuria or elevation in the labs, over the course of their disease. And of these 40% that do develop this chronic kidney disease, 10% of those will then progress to ESRD. So some studies estimate that if a patient has lupus nephritis, that 10 to 30% of those will progress to kidney failure. And there's different factors and degrees of the lupus nephritis that lead to the variance of those numbers. And so, the one thing I do want to mention if you're a lupus patient is, in my world, there's other forms of kidney disease. There's things like membranous nephropathy, IgA nephropathy, focal segmental glomerulosclerosis, lupus, diabetes. These are some of the major ones. And these other diseases can come back and affect the new transplant, and we have to deal with that. Some can come back at the rate of 30 or 40%. But lupus is one disease which has the lowest or most rare kind of rate of recurrence after transplant. So once a patient has lupus nephritis and kidney failure, their rate of that lupus affecting the transplant is probably the lowest of any other major diseases of kidney failure. So that's a little bit of a relief. And some literature quotes, some literature quotes 0%, some literature quotes, between 2 and 11%. In my 9 years, I can count on less than one hand how many times we had lupus recurrence. Some of the risk factors for recurrence are young age, a Black non-Hispanic ancestry, and female. There are some data that suggests that Plaquenil or hydroxychloroquine can decrease the rate of recurrence in some observational studies, but not all patients with lupus are on that after transplant. So that was just a bunch of slides I kind of put together to introduce you to the world of kidney transplant, connected a little bit to lupus, and I think maybe now we'll pause for some questions that had been brought in, I think, this week about this topic.
Yeah, thank you so much, Dr. Reddy. That was a great overview. We do have community questions, so we'll just dive into those right away.
Okay.
Um, you talked a little bit about some of the causes and different conditions, obviously, that can cause issues within the kidneys, but to your knowledge, what causes someone with lupus nephritis specifically to usually need a kidney transplant? Like what's going on in the kidney that requires that?
So essentially the question is like, if you have lupus nephritis, like, what is causing it to make your kidneys failed? And I think um, that's a pretty complex question, and I think there's a lot of variability. So a lot of that comes down to like, what is the biopsy of the lupus show on the kidney biopsy? Some of these like very proliferative lupus nephritis will progress to kidney failure, at a faster rate. So it's often, decided by what we see on the pathology of the kidney when we biopsy it as to what causes it to progress faster than the others. Some lupus nephritis are less aggressive and they won't, progress as frequently to end-stage kidney disease. So oftentimes it comes down to what's on the biopsy of the kidney.
Okay, got it.
And then
Uh,
and then you have to think like, if when let's take that question again, like, when do you need a kidney transplant? So
Right.
a patient is a candidate for a kidney transplant if you're on dialysis, or if your GFR or your glomerular filtration rate or the percentage of kidney function is less than 20%. So you cannot be considered for a transplant if you're at 30% or 40%. Only has to be less than 20, or you're on dialysis, and then you can be considered for a transplant.
Okay. Our next question here is once you get a transplant, what medications do you have to take forever?
Yes. So and there's a big three that I tell my patients that we use for the majority of our patients. There are
Okay,
other regimens, but the majority of our patients are on something called tacrolimus. It's a calcineurin inhibitor. It's taken usually once or twice a day, and we check blood levels of it with every clinic visit. And based on the blood levels, we either go up or down. That is like the main drug we use. The other two drugs are very known to probably all of you guys. One is mycophenolate, Cellcept or Myfortic. That's our second biggest drug.
sure.
We give that twice a day. And our third drug is prednisone, a lupus best friend drug. But we only use 5 milligrams of prednisone. So in lupus, if you think about some of the, you know, side effects you had with prednisone, we don't see that to that degree because we use 5 milligrams of prednisone that the patient usually takes for the life of the kidney. And those three medications represent the bulk of our immunosuppression for the life of the transplant in the majority of our patients.
Got it. And in looking at contraindications that you were speaking about earlier, if someone is already on like a steroid or an immune suppressant medication that's affecting, say, like their white count, would that prevent them as a candidate, or would you wait for labs to normalize before operating, or
Not
their lab
not all,
markers?
yeah, not always. If the white count is a little abnormal, that shouldn't affect us too much. Again, because of the overlap in transplant in lupus. So what if you're on Myfortic and prednisone? Because we're going to put you on that anyway. So
Sure.
for me, it's like a plus actually, because sometimes these drugs are hard to tolerate. Myfortic, diarrhea, nausea, vomiting. If I know a patient's already on it and taking it, I mean, I think it makes our life easier. And I think because of that overlap is why you see the recurrence rates of lupus being so low, because we probably use more immunosuppression than a lupus patient is getting. And so all of that immunosuppression together will suppress their lupus too.
Got it. So if someone was having an issue with like a recent infection, that the labs and the infection would be up to the discretion of the nephrologist or the rheumatologist.
Yes, the infection could be a potential problem. So let's say you got a lupus therapy and you're immunosuppressed and you had some severe pneumonia, and you got called for a kidney transplant. We probably would skip it at that time, and let you get through the pneumonia and wait for the next kidney to come.
Okay, got it. Um, how long can you stay on dialysis until you need a kidney?
So if you're on dialysis for a day, you need a kidney. So everybody on dialysis is in need of a kidney. So essentially that question means like, how long can I live on dialysis? right?
Right.
And so that's going to be different for everybody. The mortality at 5 years I showed you is pretty high. And
Yeah.
so the sooner you can get a kidney, the better. And that's why living donation, getting everyone to know about your disease, to see if they could be a donor, to get tested, that's going to be key. So the question isn't like how long can I live? Because we did a transplant last week. The guy was on dialysis 10 years. And I can
Wow.
I can tell because our average wait is 8 to 10 years. So that's sad, but that's the norm for us. But that man that's been on dialysis 10 years, like all the people he started dialysis with in 2013, like very few have made it to this point. And now he has to get a surgery. And like, he went through that 10 years of like, you know, struggle, like even his ability to improve after transplant is going to be dissipated. But let's say he was on dialysis for 10 months because he got a living donor, the equation changes dramatically. So you can live, beyond 10 years sometimes on dialysis, but the goal shouldn't be that. The goal should be looking at dialysis as a bridge to your life of transplant, and what can we do to shorten that bridge?
Yeah, absolutely. Hearing you talk about the One Legacy waitlist times being higher in SoCal is absolutely wild.
Yes.
When you highlight that local centers compete for organs within the One Legacy program in SoCal, is that straight time on the list and blood type in terms of who gets a kidney? Like those are just
Yes.
factors.
Those are the factors. So there's no like, wheeling and dealing that can happen. It's just like when did you start dialysis? When did you start dialysis? And then based on the blood type.
Sure.
There are some, nuances to the allocation. So some pediatric patients, won't have to wait as long and they tend to get the better kidneys. And some people that need two organs will jump the list. So if you need a liver and a kidney, then you don't have a 10-year wait. You go right, towards the top. So there are some nuances, but in general, for someone that's just waiting on the kidney list, it's your blood type and then how long you've been on dialysis, that essentially determines your position.
Okay. Makes sense. Our next question is, will your second kidney be affected if you have a transplant if you have lupus?
So that's like asking about the recurrence. So
Right.
again, recurrence is rare. I wouldn't say it's zero, but for all the other kind of, diseases that affect the kidney, lupus is the best one to have in terms of like, you know, rates of recurrence.
Perfect. And we got a question just submitted. What is the pain situation after
Pain.
surgery, and how long do most people need to take pain medication after being discharged?
I like that. So I would say, for some surgeries, you go like two steps back before you go forward.
Sure.
Some you go one step back. I think kidney transplant is a surgery where you go one step back. So it's core muscles that are affected, right? So it's intra-abdominal. So even like, you know, turning from side to side or getting up from a bed position to standing up, you'll feel it because it's your core muscles. So there is a little bit of pain, but I would say it's probably not that bad. Most of our patients are not on pain meds by the time they're discharged, and some are on pain meds, but there are very few patients on pain meds beyond 2 weeks. And payments are, they have their own risks. So if some patients are just so used to taking pain meds, a lot of them can get constipated with the abdominal surgery and pain medication, and then it kind of perpetuates even more pain. But I would say that for the most part, pain is not a huge thing for us. We are a center that does a lot of nerve blocks too. And so the nerve block at the time of the transplant surgery has helped our patients, like in terms of like the few post-op day pain. Um, Not a particular pain is usually not a huge part for us. I
Okay.
mean, it's a surgery, so there's going to be some soreness, right? But it's
Hmm.
it's not particularly painful. But I will tell you that whatever pain is happening, um, the bliss of seeing a Foley bag full of urine for a patient that hasn't peed in like 5 years, it's a pain is worth tolerating.
Sure. Absolutely. And then our last question here, what does the donor have to worry about in terms of health issues after donation if my family member is donating for me?
I love that question because when I talk about living donation, I speak to about it like I take it for granted, like, oh, there's so many donors out there. But the truth is, for a transplant program, it is the donor's health that is first and foremost for us. So when all our donors that have donated, I warn them ahead of time that it's gonna feel like we don't want your kidney. We're gonna do so many tests on you that you're gonna wonder like, are they just trying to rule me out? But we're not. We're just trying to cross like every T and dot every I to make sure that that person is healthy. The This only works when you have, a sick person and a healthy person, and the healthy person donates a kidney and the sick person is better, and the healthy person remains healthy for the rest of their life. So things that we tell our patients that donate are one, I'll go over the donation process. So once they're cleared, and I would say if I get 10 donors, maybe one or two are cleared. So like eight or nine, we either find
Wow.
something or they're not good enough or they're overweight or they have risk factors themselves. So we're pretty stringent. So if you're a living donor, you're like usually in tip top. So if we do it, we do most of our living donors on Monday. Living donors usually go home on Tuesday or Wednesday. So the only 1 or 2 days post-op. And then after donation, there's no medication they have to take. There's nothing they essentially have to do other than just maintain good habits about hydrating well. So I tell my patients, like, when you have one kidney, you want to really make sure you're one of these people that carry a water bottle. Make sure you're not like peeing like super yellow urine, and hydrate your body well. We like to avoid like ibuprofen or NSAIDs if they have pain. So we're asked them to take Tylenol if they ever get pain. As far as diet, they can pretty much do what they want. When you have one kidney, when you donate a kidney, probably the thing we will say is like avoid these like high protein, only keto, all keto, everything diets. Probably not best when you have one kidney, but as long as they have a reasonable, balanced diet and they take care of themselves, there's nothing really they need. They don't need to take any medications. We will follow them up at 1 month, 6 months, 1 year, and 2 year, and we recommend they just get their blood checks regularly. But when you donate a kidney, after you donate one, the remaining one will grow in your body. So you won't be kind of like 50, you won't lose 50% of your kidney function. You'll gain some of it back because the remaining kidney that we retain will grow a little bit. Kind of like a woman in pregnancy, your kidneys grow a little bit to meet the fetus's needs. Your uh
Wow.
your kidney will grow a little bit. It won't be like as if you're having two, but you can live a healthy, normal life with one kidney if you've been pre-screened. And let's say, and it rarely, rarely happens, but in the worst case scenario, if a person that donated a kidney went on to need dialysis, the way the allocation system is there's no wait time. They would go to the top of the list and they would get a transplant even probably before they started dialysis.
Wow.
And that rarely happens, but that's just kind of a safe cap that we have.
Very cool. Well, thank you so much for your time, Dr. Reddy. This was really helpful. If any viewers are interested in learning more about your practice or UCI's kidney transplant program, should they just head to the UCI Health site?
Yeah, there's at the UCI Health site, there's a link for the UCI Kidney Transplant Program, and you can find more information in there. And we have some videos too. And yeah,
Oh, okay, great. We'll link that in the comments then. Thank you so much for joining us. The recording of this session will be available for a replay here on Facebook, as well as Lupus LA's YouTube channel to follow, in case there are any sections of the talk that you'd like to hear again. That was a lot of information. And make sure to follow Lupus LA on social media so that you don't miss out on upcoming events that we have like this one. Thank you so much, Dr. Reddy.
yeah. Thank you, everyone.